to all of your speakers and panelists. That was absolutely fascinating. There are lots of questions going into the chat. Some are getting answered. I think some will be answered by the materials from today's call being made available for people to review. But please feel free, speakers, panelists, to answer questions that you see there that are directed to you. We were always going to be short of time, of course. That was an excellent first session, introducing us to the current epi and transmission dynamics and what's known about them to date. We move now into session 2, which will be chaired by Libby Higgs. Are you here, Libby?
I am here. Can you hear?
Brilliant. We can. Thank you very much.
All right. Well,
I'll hand over to you.
Thank you, Iper. And it's my pleasure to chair the second session focused on natural history and to emphasize how important multinational coordination is in a context where we have, contacts and patients spread across the globe, literally in 20 plus different countries. And as we are all aware, if we generate knowledge on understanding the natural history, this informs not just current care and approach to patients and better patient outcomes, but transmission prevention, public health measures, communications to the larger society, and preparedness for future outbreaks of Hanta. So our goals really are to understand natural history to improve patient outcomes. And also, as we understand disease pathogenesis, this helps us inform both timing and types of interventional studies that we can do in the future or now, and understanding how to prevent transmission and future outbreaks. So we're going to start with a focus on clinical management. And we have both Jamie Rylance and Janet Diaz. Janet's the head of the Safe and Scalable Care at the WHO's WHE. So Janet, over to you.
Thanks, Libby, and good afternoon, good evening, good morning, colleagues. And I'm actually going to give the floor to Jamie Rylance, who works on our team as one of the case management experts, and have us walk us through these slides, and I'll be present on the panel. So over to you, Jamie.
Thanks very much. I don't think I'm going to tell you anything that you don't already know, but I did want to emphasize some pieces of learning that we've had in terms of the integration of research and clinical management during outbreaks. So I'm Jamie Rylance, as Janet says, within the Safe and Scalable Care Unit in the Emergencies Programme. I'm going to talk about three things. I'm going to talk about providing optimized supportive care for all patients. I'm going to talk about standardized data collection, and lastly, about ensuring an ethical framework for the treatment of patients where we have experimental or unproven therapeutics. And I won't go into details because we're going to have that discussion later. But essentially, optimized supportive care is about raising the bar for all of the patients in all of the studies, whether they be just in observational studies or interventions. And in this outbreak here, we may see, particularly across critical care units, that there isn't a huge difference in practice, but that's not always the case in outbreaks. And certainly harmonizing the practice to the degree possible is very useful because it reduces the differences attributable to supportive care and the therapeutics and approaches that we might wish to see the effect of. Of course, this is an interplay of the virus, in this case, the healthcare that's delivered, and the patient themselves. That supportive care is intended to improve baseline outcomes for all, and I'll give one example on the next slide. But communication between clinicians is also key. That may have an onward effect that practice becomes more harmonized. And that's certainly, I think, that peer-to-peer learning has been the case within this hantavirus outbreak. I'll move on to the next slide here. This is not from hantavirus, but it's an example from Mpox. And it shows that, I think, a case study really in optimized supportive care, both for the good of the patients and the good of research and scientific knowledge. They started with making sure that fundamental clinical interventions, triage, monitoring, all of the supportive care, in this case through to the ventilation and organ support, would be standardized. This randomized control trial in the Democratic Republic of Congo looked at tecovirimat as a intervention for clade 1 mpox virus infection. And historically, mortality, particularly in the regions where this study was done in DRC, was upwards of 4–5%. When this study was done, however, the concentration on improving clinical care reduced, we think, mortality in both arms. There was no difference between the therapeutic and the control arms, but you can see that the mortality of 1.7% in both of those was much lower. And clearly that demonstrated, it supported the hypothesis that supportive care was actually one of the best things we can do to improve patient outcomes. As I said, that might be less heterogeneous practice in this hantavirus outbreak, but still the communication and that harmony is important. Harmony, though, not just in the way that we treat patients, but in the way that we collect data and do analysis. And this example, well, there's multiple of these. The WHO and ISARIC in the early days of COVID harmonized a data collection system so that the WHO Global Clinical Platform and ISARIC partners were able to collect data and really help understand the things that have already been mentioned: risk factors for disease, what the natural history is and the disease progression, the complications and the outcomes, and was used in other circumstances where investigational products might be used outside of a randomized control trial to support implementation of that and to enable the comparison of patients from multiple different settings over time, with all of the caveats that that requires. It's also important to note that the standardized data collection within clinical practice is probably an on-ramp to randomized controlled trials when possible, although I see that certainly what we hope is that this outbreak is contained enough that we would never recruit enough people to randomized clinical trials. It's important for future patients to understand the best that we can with the data that we have available. And this just describes, I think, another example from Ebola virus here, where all three of these approaches were combined to underline that we need to optimize supportive care here in circumstances very difficult that most of the hantavirus patients find themselves, but noting that even within this outbreak, we have people in remote islands, we have people in intensive care units in Europe, and we have people at different stages of the disease. So really still important that we establish good clinical practice across the board. And that's been the case in a lot of our clinical discussions we've had as part of WHO partnerships over the last 2 weeks. We're going back to Ebola, though, the progression from that optimizing supportive care and the collection of data under a MURIS, that's the monitored emergency use outside of research, through to the randomized control trial, which demonstrated the effect of therapeutics and the first really breakthrough treatments for Ebola was fairly linear, and each of those items supports each other. In this hantavirus outbreak, just to reaffirm, I think, our commitment to bringing people together, the clinicians that we have had on our calls to exchange information, to question and to understand both the basic pathophysiology through to how we treat patients, looks over all of the countries that are currently looking after patients and the clinician networks that support that, and the experts, some of whom are on the call today from the Americas, where there's clearly a lot of historical evidence, at least in terms of clinician experience. So again, nothing that you didn't already know, but really to emphasize, we want to optimize the standard of care to bring equity across all of the patient groups and to ensure that we can use the data most effectively when we collect it. This hantavirus outbreak shows we've got multiple investigator sites, we've got multiple agents being used, and we may discuss them later, antivirals and immunomodulatory agents of many different types, and as I alluded to, multiple environments. So all of this standardization and common coordinated data approach are going to be really important. I'm going to leave it there and just turn over back to Libby and the panel. Thank you.
Thank you very much, Jamie. And I see a lot of good questions in the chat. I hope we answer some of them during this session, so please be patient. Next, we're going to hear about an attempt, an endeavor called NAVIS. It's a natural history protocol involving all of the countries that are caring for contacts and cases. And Dr. Roger Paredes from Barcelona, Spain, and the lead for the Infectious Disease Research Institute and Foundation to Fight Infections, has been leading this effort to develop the protocol. And we have reached version 1.0, and that will be going out broadly today. So Roger, over to you.
Yeah, well, thank you very much. Can you hear me well?
Very well.
Okay, thanks. So first of all, it's an honor for me to be here, and I am presenting on behalf of the NAVIS protocol team, which is an effort that has been developed in very short time, and thanks to really a global leadership. So this is the most important slide, is that whatever I'm going to present to you is due to, very quick and strong effort from a lot of people. And those people are here, and institutions and different institutions who have been able to work together in a high quality manner, and also with lots of generosity. So why NAVIS? As you've seen, and without getting into more details, there are transmission uncertainties that still remain. There are lots of early detection challenges, and also questions that actually many of the questions in the chat are extremely important, and we hope to be able to at least answer or learn more or get closer to answering them through NAVIS. There is a huge need of evidence-informed policies, both to support risk-based public health measures, balance effectiveness with social and economic impact. And of course, NAVIS gives us is an attempt to provide proactive outbreak response. Well, in this case, it would be reactive, but quickly reactive, and anyhow, and then have a basis for also future outbreaks. So it is a long protocol, but here's the overview. So what NAVIS is proposing is a longitudinal observational cohort study, which enrolls individuals with a defined exposure to Andes virus. Ideally, so it has been designed in an ideal conditions. It should be an ideally prospective study. However, on purpose, NAVIS will allow for retrospective data inclusion, and we want this to be pragmatic. Here, NAVIS is based on a triggered-based approach, and where subjects are followed from enrollment until they become PCR positive, and then through acute illness defined by symptom onset and convalescence. However, we will also include epidemiological information from their exposure, and times will be counted taking that into account. For example, information from the WHO surveys already developed during the shift. The overarching goal of NAVIS is to delineate the natural history, but also the virologic and immunological mechanisms and consequences of infection. And what is particular from NAVIS is that we have identified a schedule of samplings which is matched to biological inflection points. And you'll see what I mean by that. We try to sample a little bit more around the key inflection points. However, we really want to NAVIS to remain a low intensity study, which limits the amount of sampling that we can do. Very importantly, clinical care is not directed by the protocol, so clinicians, all medical decisions remain under treating clinicians, and clinicians can do whatever they think is best for the patients. As I mentioned before, it remains observational, purposely low intensity. And finally, it's also extremely important to mention that it does not restrict or prevent enrollment in other hantavirus-related emergency responses or interventional clinical trials. This has it's an observational study, and hopefully other interventional clinical trials will be able to work with NAVIS or use NAVIS as a data source. The inclusion criteria are summarized here. I think these are possibly the most important ones. There is no age restriction. We had a lot of, we are not aware of children at this point, at least myself, I am not aware of children, but we decided not to have any age restriction in the protocol. So people, the protocol will include persons diagnosed with Andes virus in association with the current outbreak linked to the MV of home use, but also people exposed to Andes virus. And participants' exposure must meet one of the following criteria, which is direct physical exposure to a person with Andes virus infection, environmental and proximity exposure to a person with adenovirus infection, with some definitions here. We can go back if you want later during the discussion, and of course, occupational or caregiving exposure. Finally, ability to comply with confinement sampling and follow-up procedures. We are aware that confinements will be different in different areas of the world. Some of them will be done in hospitals or hospital facilities. Others will be home-based. There will be a lot of differences, but we want to include them all because we feel it's very important to have these as much information as we can and learn as much as we can from this outbreak. And of course, patient or relatives will have to provide informed consent. There's only one current exclusion criteria, which is imprisonment, and quarantine does not count for that. And because we decided to leave the protocol as open as possible. This is the key characteristic of this slide shows our thoughts. Okay, so this is the way we think about it. We start with a previous exposure, likely maybe in the ship, maybe outside the ship, who knows? And then there is one day when participants are enrolled. This is easy, the study enrollment. And then clinical data, lab data, and biological data collection has been structured in 3 tiers, which reflect the evolution of the disease. So tier 1 is exposure, and that one includes people who have been exposed to the virus but still are PCR negative. These participants can either remain PCR negative until the end of the follow-up, and therefore they are discharged. And here I'm saying home and should not say home, just discharged. But if the PCR becomes positive, then they move to tier 2, which is pre-symptomatic infection. Similarly, if symptoms never develop, participants are discharged, but if symptoms develop, they move to the tier 3, which is symptomatic disease, which could unfortunately end up with death or discharge. An important characteristic of the trial of this study is that, of course, participants can be enrolled at any of these tiers, which are actually mutually exclusive, which means that if someone is following someone with, if we're following someone with a positive PCR without symptoms, it would be enrolled in tier 2. If there's if he or she has symptoms, it will go to tier 3. Then the schedule of events is shown here for the first year. So we start from exposure, and then we are following individuals for up to 6 weeks. And this is because after a lot of discussion also with the experts, which are here, many of them, this virus has a long incubation period. So we thought it would be better to cover for 6 weeks since exposure. Of course, there's informed consent and epidemiological assessment, and there are clinical assessments, enrollment, and there we include daily clinical monitoring, but also blood hematology coagulation biochemistry, and then a number of virological assessments, immunological assessments. And here you can see the scheduling time. So we have distributed everything every week. So in week 1, there's only once per week. However, week 2, week 3, week 4, week 5, we moved to twice per week. And then by week 6, this is a patient who has been, a person who has been exposed but still PCR negative. We reduce it to 1, and that's it. There is an optional opt-in host genetic testing as well. This second tier is what happens when the participant becomes PCR positive. Okay, so it's a similar structure. We collect informed consent and we do the epidemiological assessment if it hasn't been done before. And then we follow participants clinically. In this case, because they have a recent positive PCR, we start with twice per week. We never go up to twice per week because twice per week would not be considered a minimally invasive testing. And then we do again biological, immunological, and host analysis with similar schedules, and the host genetics if it's not been done before. And finally, for tier 3, this is a schedule for symptomatic disease, similar structure to tier 2. The main difference here is that the person has started with symptoms, and as we know, we try to sample as frequently as possible because in this framework, which is twice per week, because we know that the clinic, if patients progress, they can progress very quickly, and we really want to know. We want to get all these samples and information quick. Finally, the main goal is clinical epidemiological understanding, but there's also some, let's say, advanced laboratory research which is attached to the protocol. One is the host genetics opt-in study led by Ken Bailey in University of Edinburgh. And also, we want to point out that we understand that there are many different countries, many different labs that can do lots of things, but there might be situations when there is a particular lab or site that does not really have access to advanced research laboratory investigations included in the protocol. And this could be performed at our lab at Irse in Barcelona. And these are the type of assays that are included in the protocol. In order to do this, people will need to contact Julia Blanco or Victoria Luceros, and they will distribute the work. There will be, of course, a policy of data sharing and publications, which is quite known and standard, and this is what we've done in the past. And let me finish with the key takeaways of my presentation. One is that we are proposing a trigger-based adaptive framework to align data collection with key biological events during outbreaks. Our aim is to address key outbreak uncertainties like pre-symptomatic transmission, infectious period, severity predictors, also critical for containment. We aim to demonstrate that we can embed quality observational research into an emergency response without disrupting patient care, because we don't tell clinicians what to do, but we hope to learn a lot from what they do. And finally, this framework provides a scalable and ethical model, which hopefully will help us learn a lot about this outbreak and also for future, and inform future global health decisions. And with that, I will stop leaving and stop sharing.
Thank you, Roger. So many great questions in the chat, and this protocol will be disseminated. So I think a lot of them will be answered. Hopefully it's designed to address the many issues that are spot on that are coming up in the chat. And outbreaks, as we all know, take place in communities. They involve people, and our society globally is sensitized, certainly from the pandemic. And there's been many concerns that the hantavirus outbreak is going to be the next COVID. So our next talk will be risk communication and factors affecting adherence to public health and social measures from experts Charles Simmons and Richard Amlott. Charles is an expert in emergency preparedness behavioral science, and Richard is a professor and deputy director of the Behavioral Science and Insights unit, and an expert in emergency preparedness as well. So thank you both, and over to you.
Thank you very much. And thank you for having us here. So I'll be presenting work that our team are set to deliver from next week. We're the Behavioural Science and Insights Unit in the UK Health Security Agency, so I'll be speaking primarily to a kind of a UK context. So we know from previous research, including some qualitative research that our team did with British nationals who'd been isolating following repatriation from Wuhan in early 2020, that barriers to isolation in home settings can include running out of supplies or losing money due to not being able to work whilst isolating. And facilitators can include things like practical measures, such as receiving practical and financial support, as well as more perception-based variables, including higher trust in formal institutions, higher perceived importance of isolating in terms of the health benefit to self and others, and perceived kind of self-efficacy, one's own capability to adhere to isolation guidance. And then for supported isolation specifically, there are the additional barriers of concerns around boredom, uncertainty about what supported isolation might involve, concerns around transmission risk. And then the facilitators for supported isolation will include understanding why it's necessary, that it protects family and friends, as well as society more broadly, and other aspects of the way that it's that supported isolation is managed, positive treatment and proactive regular communication by staff in settings, an approach that relies on kind of an absence of coercion, more of a focus on support. Oh yeah. Sorry
to interrupt. The slides are not moving for me. Are they moving for?
Oh yeah, that's I will get onto that. There'll be less of me yapping on each of the subsequent ones, I can assure you. So that other facilitators for supported isolation might include understanding why it's necessary, and yeah, support and promotion of voluntary adherence being the focus by staff of those settings. And then other things like actions taken in response to feedback already provided by guests, and just general faith in the effective management process. Risk communication can address many of these factors, but for some of them, more kind of sustained practical support, material support is required. Risk communication is still important there in order to be able to promote and signpost to the relevant support. We can now move on to the next one. Sorry about the hold up there. So whilst many, including those in our team, have been endeavouring to make sure that this understanding underpins the approach that's already being taken to address self and supported isolation in the UK, things like designing guides to support people in UK isolation to overcome some of the known challenges, there is a need to pay attention and understand the particular perspectives, needs, and experiences of people who are currently isolating, to ensure that any additional concerns or barriers are monitored and then addressed as swiftly as possible. And it's also important to learn for future situations that might warrant extensive isolation periods. So to achieve this, we're running a mixed method study to gather perspectives and experiences from contacts of hantavirus cases undergoing isolation, both in home settings and supported isolation settings, so as to provide recommendations to improve the present quarantine experience and approaches used in subsequent isolation interventions, particularly ones where the duration is particularly lengthy, as is the case with this one. Can we move to the next slide, please? Thank you. So the first a daily survey that we'll issue, it will consist of kind of basic socio-demographic questions, in addition to ones that relate to participants' presence on the ship, quarantine location, quarantine start date, and then participants who traveled on repatriation flights to the UK will be asked open-ended questions relating to their experience of returning to the UK and the information that they received. And then the remainder of the survey and all subsequent daily surveys will be kind of rapid closed questions focused on health, well-being, social support, hantavirus perceptions. And these have been informed by previous work and have like validated measures like the Spielberger State Anxiety Scale. Next slide, please. Thank you. So in addition to the daily surveys, once a week, participants will be sent a link to a diary exercise. They'll be asked to a series of open questions focused on personal well-being, experiences of isolation, and views related to the hantavirus outbreak and how it's being managed in the UK. And it will also include questions on experiences of deciding on where to isolate, moving locations during isolation if applicable. And the prompts used for this will have been informed by previous research conducted in isolation and factors affecting it. And we'll use open-ended questions to ask people what they need to help with their isolation in the immediate situation. And there's a plan to use an AI tool that we have access to in UKHSA called Trace, which can be used to support the coding of data provided to us in this part of the study. We've tested it out and confident that it can allow for fast but robust qualitative analysis, but only with the oversight of trained human researchers. And our aim is that if it emerges that there are improvements that can be made that aren't being communicated through any of the other channels to the experience of those quarantining, that we can advocate for these improvements to be made during the course of the isolation period, so as to safeguard adherence, whilst also ensuring that we're doing right by the people who are doing the work of keeping the rest of us safe. Next slide, please. And then the long-term plan is to recruit participants who will have taken part in the previously discussed component to take part in an interview 1 month from the end of their isolation period, akin to what the team previously did with the following the Wuhan repatriation. But what we should be able to do this time around is, which we haven't, as far as I know, been able to do previously, is we can use the analysis of diary entries collected during the course of the preceding part of the study to tailor interview guides for each participant, so that the interview can be even more insightful than it might otherwise be, which should really help to advance our understanding on adherence to this particular and important public health social measure. Last slide, please. So that summarizes what we're up to here in UKHSA, and particularly in the behavioral science unit in UKHSA. If you have any further questions that aren't addressed today, please do feel free to email us on the email address that's presented on the slide, bsiu.response@ukhsa.gov.uk. I have finished speaking. Thank you. I can't hear you.
Libby, I think you're on mute.
Apologies. Thank you. Clearly, there's a need to leverage and harmonize what you're doing to across the country. So maybe we should talk about that in the context of the NAVIS study. Okay, we're going to turn now and take some questions, not just for the speakers, but also some additional panelists. If you all could turn on your cameras, that would be great. Sadly, we have so much expertise and only 14 minutes, so I've asked the speakers to limit their questions to their responses to 2 minutes. We're going to focus first on infection dynamics and early detection. So Roger, you did a good job explaining the NAVIS PCR testing strategy and concurrent viral sampling. Could you just go into a little bit more detail about the rationale behind this approach and the importance of what we hope to learn?
So yeah, thank you. As Gustavo has mentioned before, I mean, on one hand, incubation period can be very long, and then it seems that the transmissions occur very closely to when patients develop symptoms. However, we don't know a lot, and it would be Navis is trying to accommodate sampling even before patients develop symptoms to nail down which are those windows, and also by attempting to grow viruses from obtained samples, see in a more systematic manner when are those viruses actually infectious, because there are many questions open. PCR is most efficient in blood based on what we know today, but we are also sampling obtaining respiratory samples. And also in a few patients, if patients allow and accept, we might also collect, there's room for collecting semen, for example, because we know that virus may be in semen for prolonged periods, and this is going to tell us a lot. So yeah, the idea is to have a systematic framework where that allows us to explain and get a better definition of those extremely important questions.
Thank you, Roger. And next, we'll turn to Jenny Johnston from University of Toronto, who's an infectious disease physician and clinical research lead of PRECISE, which is a federally funded pandemic preparedness network focused on diagnostics. Jenny, I know from previous calls this week that you have an at-home quarantine strategy. I'm just, if you could share with us what your approach is for following those contacts at home.
Yeah, thank you very much. And so again, the goals of PRECISE are really to bolster our pandemic and emerging pathogen response focused on diagnostics here in Canada. And so what we are hoping to do is really do that clinical manifestation, natural history, and understand also the optimal sampling strategy for these patients. So in the case of hantavirus in Canada, the decision by public health was to quarantine asymptomatic contacts in their home, which again meant that we had to pivot somewhat in terms of how we were going to do that. We work very closely with public health, and so what we were able to do, for any of the asymptomatic patients, they had a initial assessment whereby they had serum, plasma, as well as NP swab, nasal swab, saliva, sputum, as well as a buccal oral nasal swab. And urine. So again, just to do that at baseline, but then we were able to give them kits to take home, for which then they are doing serial sampling. This includes dried blood spots on day 1, 7, 14, and daily swabbing of the buccal, oral mucosa, and saliva and urine for 14 days. So again, that's done serially. In addition, we'll do serum plasma sampling day 21, 30, day 120, day 180, and day 365. So moving, and which will be a lot easier once they're out of quarantine, of course. And if they become symptomatic, then they would be managed and admitted in a special in our special care areas at hospitalization. And then we would amend our sampling strategy, which would be broader. We are keen to align with Navis, of course, to be able to contribute to those data.
Jenny, that's very interesting, comprehensive approach, something that I think Roger would also be helpful to share through the Navis network of investigators. So thank you. Richard, what psychosocial supports do you advise for contacts and patients during prolonged quarantine and care?
Yeah, so very happy to sort of reinforce some of the messages that Charlie covered in his presentation. I think I'll start by saying that very often when we're thinking about the requirement for isolation and the importance and consequences of poor compliance with isolation, there is a tendency to move quite quickly to thinking through the legal mechanisms to compel people to adhere to isolation. Now, one of the things that we most often find is that the vast majority of people, when they understand the requirement for isolation, they're often very willing to undergo, to follow our guidance and to undergo the process. And so the barriers are primarily associated with people's ability to undergo isolation rather than specifically their willingness. And when we see people who are largely unwilling, it's usually as a result of some form of unmet need. And that can range from simply needing a mobile phone charger because they like to charge their phone and being able to call their friends and family to check in and make sure that everything's okay, to circumstances where individuals might have really significant caring responsibilities, such as a family member in hospital or similar, where there is a need that they really must meet. Now, on that basis, one of the first things that we should be doing is starting with supportive conversations to help individuals who are being asked to isolate to problem solve those challenges. And those challenges could be, as Charlie set out, financial, practical. They could be to do with medication. It could be caring responsibilities, and it could be the psychological burden associated with having to isolate for an extended period. Now, our task is to understand what those needs are, understand any that are potentially unmet, and find ways to help individuals to problem solve. And that is, for the vast majority of people, going to be the key to helping them to follow our public health guidance and advice. So I'll stop there, Libby.
No, it's super helpful. So identify the needs and meet them. Right.
We may not be able to provide complete provision for people. What we can certainly do is we can certainly help them think through and address any of the challenges that they might have. And there may be some circumstances where there are individuals who are less able due to their circumstances. It could be their financial or their social circumstances. And then in those circumstances, we certainly should be looking to intervene with additional financial support, with additional social support, and more to meet those needs.
Terrific. And I hope we can connect with you via the NAVIS approach. We're going to turn towards transmission characteristics. Clearly, this is extremely broad. And to Dr. Kenneth Bailey from University of Edinburgh. He is an ISARIC investigator. He's a co-PI on the NAVIS protocol, and he is leading on the opt-in genetics study. So, Kenny, how does research improve public health studies of transmission potential and shedding patterns? Very, very broad question. And then if you could, how might host genetics be informative in understanding disease progression and transmission?
Yeah, thank you, Libby. I'm not an expert in transmission, but it is always necessary or valuable to link clinical data to the samples that we collect from patients. All of those things can be done in most countries under public health legislation, but it is very clear from our experience dating back for 20 years that if you get research consent from a patient, then you can do so much more with the data and samples that you collect. You can share them so much more easily with collaborators. And it is also very valuable that you can make a vaccine or a monoclonal antibody or a serology reference standard from the samples that you acquire from patients. So I would encourage everyone to get a protocol through ethical approval if you don't already have a generic protocol approved in your region. Obviously, the ISARIC WHO clinical characterization protocol is very flexible and can be used for this outbreak. If it is not already in place, then the NAVIS protocol is a really fantastic way to tackle this exact problem, and it will enable you to get research consent. You can also then do a range of other studies, and that includes host genetics, which is, historically has been often, not the first priority, and I think that's still the case, but it is potentially very valuable indeed. Genetics uses natural variation to test the effect that a drug might have on a person. And it's one of the very few ways that we can get a robust hypothesis test without doing a drug trial. And it, in fact, has been very effective in previous outbreaks, including COVID, where it was a genetic signal that pointed directly to baricitinib as an effective therapy. And that's why we included baricitinib in the recovery trial. So collecting DNA and consent from cases and contacts is a very powerful way for us to identify the mechanisms of disease. And that could be transformative for therapy with sometimes quite a small number of patients.
Thank you very much, Kenny. And again, this is an opt-in and part of the NAVIS protocol with a separate consent line. So thank you, Kenny, just to endorse the importance of participation if your participants and patients are comfortable. So next, we're going to turn to Frank van der Wigdank. I'm sorry, Frank, if I did not do that well, from Rabat University in the Netherlands. He is an infectious disease expert, intensivist, and is currently caring for acute Hanta patients at this time. Over to you, Frank.
Thanks, Libby. So can you see my slide?
Yes.
Oh, perfect. So obviously there is a huge team around from Leiden and Utrecht and Erasmus and people at Rotterdam, RIVM, and I especially want to mention Chantal Rovers, who are coordinating a lot of this outbreak here, a professor in outbreak management with us as an infectious disease specialist, which I am, not an ICU doc, by the way. So I'm a professor in immunotherapy. So when these patients were announced, we had to be ready to see, okay, what could be their immune response? So what I did, I dove into, can you also see this slide?
Yes.
And I'm sorry if the ref is like this, but this is the publication from Gustavo, who also is here. And I dove into those tables, supplements, and there is something very striking. Let's see here. So if you look at yellow and, well, yellow is the ones that are mild and they survived. And then we have all these panels that were done in the serum. It's immunological markers. I picked out, if you just look by eye, nothing analytic, computers, or whatever, you look at it, it's a very striking signature. You see high IP10, you see high MIG, which is 6CL9, low IL-6, high IL-18. What is important in this, I'm not going into the details, but what's here is a very striking signature, but it was in all of them. So they were mild and they were severe. So that's something to keep in mind. Then the next thing, I was expecting, if there was a low IL-6 in the table, should we then also measure low IL-CRP in those patients? There is a high IL-18, a reflection clinicians will know is ferritin, which we see in mass HLH. Would that be seen in the patients? And this high mix CXL9. So I'll go a bit fast because I have to do. The other thing was that in literature, a high D-dimer has been described. And it's a leakage syndrome. So I was thinking, was this like COVID? We did some work on the bradykinin signaling, and I won't go into details, but just purely, is there a leakage and could this be a marker? So that far, we thought, like, if a patient comes in, we should think about this pathway, which is on, and it should maybe remind us of macrophage activation from HLH. Could ferritin be a marker? That's one thing. The other thing is that bradykinin, and we did this by blocking this pathway because the leakage could be there, and a marker could be D-dimers. So just to summarize this very simple, we think maybe those two markers in clinics could be helpful. On the one hand, for the inflammation, which might be very viral specific endothelial, and the other one, bradykinin. And I know I have just 2 minutes, but just to summarize a small idea that I put together, I just put literature together. So please, this could be completely wrong, but I think it might be helpful of thinking about next things. So there is a syndrome described by our colleagues, Giamarellos Bourbulis, who is in Athens, and he names it IDS. So it's an interferon gamma-driven syndrome. And that is a syndrome in sepsis that we now recently know, and it's just published 2 months ago, that if you block gamma interferon, the patients do better. So it's very important. Little bit of different passages, but final common pathway. Second is the HCPS, and that could be the high D-dimers, and there you would have to block bradykinin. So I think those two tell us that these are the two to focus on for the future trials, or look at markers all together as clinicians to see if this is hints of those two syndromes acting together. It doesn't happen with everybody, the HCPS, so I think that's the crux, that's the most important thing to figure out. I think the ERDS happens with everybody, but it's just a little bit less and more severe. So, yeah.
Thank you, Frank.
Here.
Brilliant demonstration of how important it is for us to study not just the virology, but the immunology alongside the clinical characteristics of these patients in a systematic way. Very much appreciate that. And Janet, turning now to you to sort of wrap this up in terms of providing how these insights can contribute to the clinical care optimization in real time. And if we're headed towards development of optimized standard of care for HANTA. Over to you.
Thanks, Libby, and hello again, everyone. So in response to the question, I think it is very clear, especially by what the colleagues have just said, it's important to integrate natural history insights to identify time points where we can intervene to optimize care. And this includes evaluation of clinical interventions. So as we know, in this disease, there is an early prodromal phase, so that becomes an obvious area to test and evaluate antiviral for efficacy, and I think that will come out later in the discussion around therapeutics. And as Frank just described, we also know in some people that you can get a more severe phase where there is a varying degree of cardiopulmonary insufficiency. And this raises two areas for, in my mind, for optimizing care. First is around the supportive care. So this is really around the critical care and the supportive care interventions, the implementation of close monitoring, the treatment with oxygen, the escalation to non-invasive, to high flow oxygen. And we've seen this variety of practices in the patients being cared for now, and also the use of invasive mechanical ventilation. In addition, there is the optimization of care around the cardiovascular insufficiency, if there is some, so the best practices around fluid therapy and how cautious to be with that, the use of vasopressors and inotropes, and of course the indications around ECMO, which has been used, has been used quite a bit in the Andes outbreaks in South America, and what is the best timing and type of ECMO interventions. So I believe there's still a lot to do around optimizing care, but we also know that there's good ICU practices, and we should do the best, do the basics well. And this is actually quite key to a little bit what Jamie said, that the treatment sites, to plan your response activities, and these complications may occur, so the treatment sites and health workers, the clinicians, the nurses, the staff, need to be ready with the right supplies, the right equipment, the right training, the right expertise to care for such complications. And if you're unable to do it at your center, then a referral pathway to a center that can. So I think with most cases, most patients being cared for now in areas where we have, advanced critical care services, that's not, it's not a major challenge. But if this were to be seen in settings, lower income settings where critical care service delivery is resource limited, then we can really see challenges in delivering that type of care. The second, as Frank just eloquently stated, is the evaluation of host-directed therapies such as immunomodulators, not just steroids, but others. And this should definitely be informed by the nature of the immune dysfunction, as Frank described, associated with the virus and disease, and then tested in clinical studies and clinical trials. And finally, the natural history insights are also needed to harmonize clinical endpoints and outcomes. So if we get to conduct a trial, right, we need to know the natural history in order to set those endpoints, those outcomes, so that we can best design a clinical trial. So I leave it at there, Libby, and thanks.
No, really excellent summary. Thank you. I know that we did not address all of the questions in the chat, and we could talk on the subject of natural history and transmission and for 4 hours. As noted in the chat, there's a lot in the literature. And I just want to wrap up saying that, we try to prepare as best we can. And I think this hantavirus outbreak underscores the value of, the viral family's approach and the quirks and global cooperation in both preparedness and research response. So over, and Iper, back to you.
Thanks, Libby. It's beautifully put. Thank you to all of the speakers and panelists there. So we move on to our third session. No mean feat. We're looking at diagnostics, therapeutics, and vaccines in about 50 minutes under the steer of Yazdan Pano, who I'm delighted is chairing this next session. So Yazdan, over to you.
Thanks a lot, Iper. So first of all, I wanted to thank, of course, all the Cork team, Iper in particular, and WHO for this meeting. Second, following on what Libby said, the importance of global coordination and the fact that you have 1,600 people here shows that the Cork approach could be a very important approach, and thanks to those who created it. And finally, to say that based on an African proverb, alone you're going to go faster, and together we're going to go further. So that being said, in this session, we have 3 speakers, and then we have a panel. And I want to start by inviting Ismail Bashir from WHO to present us the overview of diagnosis approaches. So thanks, Ismail. We are going to try to keep the time as the 2 previous ones. So 10 minutes for the diagnosis. Thanks, Ismail.
Thank you very much, Chair, and good morning, good afternoon, and good evening, colleagues, wherever you are joining us. My name is Ismail, and I'm a technical officer for laboratory in unit in WHO epidemic and pandemic management. And I would like today to give you just an overview of the Andes virus diagnostic options. Next slide, please. So as most of the speakers have alluded already, right now, based on the most of the published evidence out there, we have different platforms that we can use for diagnosis at the clinical level for Andes virus. The first one being real-time or reverse transcriptase PCR, and the second option being serological assays. Just to mention that PCR already, as we mentioned, is the most common one right now, and the first kind of like technique that we are recommending for countries, owing to what has been shown right now in studies in regards to its analytical sensitivity and also the virus being produced in the body in levels that are detectable in most samples. And for the testing of PCR, the recommendation currently is to use whole blood as well as also serum and plasma. And there are several studies which have shown that the levels of this, the kinetics of production of RNA in these samples are quite sufficient for diagnostic purposes. The other technology that we can use is ELISAs, or the measurement of antibodies, IgM and IgG antibodies. And this has been used also as the adjunct to RT-PCR, knowing that sometimes the patients come to health facilities sometimes after several days of onset, and just to measure that if you cannot find the RNA, then you can also detect the antibodies which are produced against the virus. Sufficient publications have shown so far that antibody IgM response in Andes virus is also quite in the early stages, and it could be detected in the acute phase of the disease. One of the also techniques that we have seen that can be of importance, especially for patients who are dead, is the use of histochemical histological tests that can be done to show the virus in organs such as the heart and the lung. One of the rapid diagnostic tests that is currently available, but this is a caveat because it's been produced and not validated for other settings. So just to mention that at least we have 2 antibodies, rapid diagnostic tests currently which are available. And these ones for countries who plan to deploy will need to do validation at the country level to make sure that at least its sensitivities and specificities are good enough to help in the diagnostic of patients. Next slide, please. So right now, we looked at the landscape of the diagnostic, especially the PCR in the market. Unfortunately, there isn't a lot of options because the PCRs which are in the market, actually most of them are for the old world hantaviruses, and we have a few kits that are actually commercially available for Andes viruses. Just to mention that there are a lot of in-house developed PCR tests, which are at this time through our collaborations, we're able to share this information with most of the countries. The in-house diagnostic tests have been validated, and most of the new cases that have emerged actually after MVODIAS were based on in-house developed PCR protocols. So we had opportunity to share the protocols as well as the primer probes with most of the member states who can be able to order them at the biomedical companies and receive them. At the same time, there are some commercial kits which are available in the market as well for those people who will not be able to get production for the in-house protocols. In cases where both the in-house protocol and the commercial are not available, so we are giving recommendation for labs or countries to use hantavirus genus level PCR, then followed by sequencing. For serological assays, also we have options for commercial kits which are quite available in the market. Next slide, please. So since the incident in Honduras, we had a couple of consultations. First of them, we established sometime early this year a standing diagnostic guideline expert panel. These are panels which have representatives from all the regions and experts in different diagnostics, including virologists, bacteriologists, who we planned that we could call them immediately to review the evidence that are available there and make recommendations that are feasible and usable across the globe. So we had the first week of the incident, almost daily deliberations, which also we brought on board experts from endemic regions such as Chile and Argentina, as well as our colleagues in PAHO, to review the evidence and come up with a testing strategy or guideline. And this has been very, very important in sharing information and also getting evidence from all over the world. We also had one session where we called it a technical advisory group for virus evolution to get an overview of the virus and also review the diagnostic options which are available currently. In terms of facilitation, with huge thanks to colleagues in Chile and Argentina who have donated biological materials, including controls for RT-PCR and serology, as well as also PCR kits and guidelines. We're able to facilitate delivery of these kits and protocols to member states who were requiring, and this was very, very useful, and we appreciate a lot the support we received and the donations from member states like Chile and Argentina, as well as other. Next slide, please. As just to conclude, so from the deliberations that we had with the different panels and as well as the SAG-VE, as well as member states who have experience with this, we're able to bring together laboratory testing interim guidance for Andes virus. This is specific for the Andes virus, and this basically is giving laboratories guidelines on the best approach for diagnosis, also including the best or the most optimum clinical samples to use. The protocols also gives an idea about the biological risk in advance, alerting the laboratories about considering this agent as a risk group 3 and taking the necessary precautions in the laboratory. This guidance is expected to go live today, and I would like to use this opportunity as a dissemination method. I hope that we'll be able to reach to you and also disseminate from your end. I'll stop here and thank you and back to you.
Thanks a lot, Ismail. So we will keep, of course, the question for the panel. And now we're going to move to the second presentation on the therapeutic approaches. And we have the pleasure to have Marco Cavalleri from the European Medical Agency. Thanks, Marco.
Thank you, Yazdan. And here we are to say a few words about therapeutics. A lot has already been said, so I'll try to recap, but also to say what we have been discussed through the prioritization of therapeutics technical advisory group at WHO. Next one. Right, so this is a snapshot of what is out there at the moment that can be considered for treatment of cases or for prophylaxis of cases in terms of chemoprophylaxis of monoclonal antibodies. So first of all, as always, we look into repurposed antivirals, and that's, is an opportunity for me to remind everybody the importance of taking the virus, put it in the lab, and test for in vitro activity against a panel of repurposed antiviral as soon as possible. This is something that we need to do systematically whenever there is something emerging or causing outbreak. So what we know about repurposed antivirals, and I will start with the one that seems to be the most likely candidate, which is favipiravir. Favipiravir, has been tested for a variety of different viral infections, from Ebola to respiratory viruses, influenza, and COVID. And actually, it is approved in Japan for treatment of uncomplicated influenza. For antiviruses, we have data in animal models and also in vitro that would indicate that would be a suitable candidate, also with doses that are achievable based on what we know on these antiviral in humans, and therefore it's a potential option, particularly for post-exposure prophylaxis or early treatment. While probably is not going to be helpful like all the other antivirals that we have at the moment for later stages of disease when we move to advanced pulmonary syndrome. Then there is ribavirin, which of course has to be discussed because is the usual product that is always considered whenever there is a virus for which we don't have therapies because of the broad spectrum. So there is good reason for that. And indeed, it was tested against a variety of antiviruses, both with pulmonary syndrome or more, hemorrhagic and nephrotic syndrome. And essentially, there is activity also in the animal models. There is decent activity, particularly when it started early. But we have to remember that, as has already been said before, then a couple of clinical studies were conducted that were not indicating efficacy of ribavirin when the disease is already progressing. And therefore, it's good to keep in mind that the evidence with this virus, like with many other viruses, is really weak on its ability on its own to really exert potent antiviral activity. And not forgetting the safety profile of this antiviral, which is not minor. As you know, there are a lot of issues associated with the use of ribavirin. Then, there are a couple of other potential repurposed antivirals, baloxavir and molnupiravir, that of course attracted interest because they could be active against Andes virus and other antiviruses. But we don't have a lot of evidence at the moment. Even in vitro is extremely limited. Even if for baloxavir, it looks like we will need to have much higher doses than what is currently used for preventing and treating influenza. And this is unclear if it's feasible. So we'll be more to look into second generation product derived from baloxavir. But would be good to see in vitro testing with these antivirals. And molnupiravir, also there is no data available in the literature, but it looks like it could be active against antiviruses, including Andes virus, and will be very important that this is tested as soon as possible to understand if also could be a suitable antiviral to be used in patients. And there is also a pipeline of other antivirals, and please indulge with me if I'm not included all the products under development, and maybe some of the products from some of you online now that certainly are of interest. So please reach out to WHO, provide information so that all antivirals that are out there can be looked at so that we understand what are the best options. But just to mention a couple that are published in the literature, So Grifcin, which is a lectin product, it has some data that have been published in the literature, and also coumarin derivative seems to have some in vitro activity, but no more than that. And these will be really early preclinical candidates, so not really helpful in the context of this outbreak. But it's important, to have a good overview of what is out there, and maybe products that would be worth pushing for further development. And really an important area that we need to push for further development is monoclonal antibodies with the neutralizing activity against this virus, and maybe having a pan-anta activity, which would be extremely helpful here. And indeed, there are some reports in the literature about a few of them that seems to be quite promising, both in terms of in vitro activity and activity in the animal models. We heard just now about immunomodulators, because an important factor is that once the disease becomes pulmonary and more severe, antiviral most likely will be totally ineffective, and therefore the focus should be beside supportive care to really think what else can be used. And there are a variety of immunomodulatory agents that could be considered. You already heard about icatibant, a very interesting approach, but also vandetanib has some data reported in the literature, including animal models, even if not always that positive. You already heard about methylprednisolone not being effective in a randomized clinical trials with more than 60 patients, studies conducted in Chile a while ago using high dose, which demonstrate that, it was not really helpful for the patient, but at least it was not detrimental and did not have a negative impact on the viral load at that point. But there are many other immunomodulator agents that could be considered. Emapulumab, we heard about that. Vilobelimab is also an interesting product recently approved, affecting the complement cascade. And there are a few others that should be considered. This will be discussed in the future by the TAG for prioritization of therapeutic to see what are the best options. Next one. And just to say, in terms of data, but I will show just a couple. This is a quite interesting study done in the Amsterdam model with intraperitoneal challenge of the virus, and which is not a minor point. So the disease is very fast in the Syrian hamster, but mimicking, closely what is happening in humans, except that it's much faster. And what we see here is that essentially favipiravir demonstrates really efficacy and protects the animal from lethality, but only when this is administered quite early after the challenge. So if you wait too long, if you wait like 5 days, from 5 days to 6 days, favipiravir is totally ineffective in this animal model. And what is interesting, and you see here in the slide in the box, is that day 5 is when viremia starts to pick up. So the signal from the animal model is that when viremia starts to pick up, then the chances that your antiviral will be effective will be diminishing. Now, of course, this is a model and everything is happening very rapidly in the animal model, but nevertheless is an indication that most likely antivirals should be positioned, first of all, for post-exposure prophylaxis, considering also early treatment, but there are some uncertainties that have to be highlighted here. Next one. And then another point that has been mentioned already is the presence of the virus, in the so-called viral sanctuaries, like in the testes, in the semen. It looks like, this virus is also could have the same type of profile, and we've seen with many other viruses. This is a paper on a single case that really illustrates that the virus was staying in the seminal fluid for a very long period of time. This was coupled, with very high level of antibodies, including neutralizing antibodies. And this is a reminder of the importance of looking into these aspects of viral replication and viral sanctuaries, and what are the implications in terms of transmission down the line, but also a reminder of the importance of having antivirals such as small molecules that could really clear these sanctuaries from the presence of the virus. So another aspect that has to be kept in mind when thinking about therapeutic intervention with an antiviral activity. Next one. And then coming to the discussion that we just had with the therapeutic prioritization tag. The conclusion there for the moment in the first meeting has been that repurposed antivirals and immunomodulatory agents are classes of agents that should be considered for rapid clinical research evaluation. The antivirals should be really considered, first of all, in the context of post-exposure prophylaxis or early treatment in the prodromic phase. And among the repurposed antivirals, favipiravir is the candidate to be prioritized based on the available data, which is a combination of preclinical data against antiviruses together with clinical experience, including safety and pharmacokinetics, that would allow a proper dose selection based on the known EC50, EC90 against Andes virus. And of course, good to confirm with this virus, but we would expect that pretty much will be along the line of what we've seen with other Andes viruses. Then ribavirin has not been effective in the treatment of pulmonary syndrome with this type of viruses in clinical studies. And despite preclinical data and anecdotal clinical experience from Argentina, my support is used for post-exposure prophylaxis or early treatment. The safety profile and the uncertainty around the benefit risk would reduce its suitability, at least as a priority antiviral to be considered at this stage. Next one. Then when it comes to other repurposed antivirals, such as molnupiravir, again, as just said, we need really to have a rapid system of testing them in vitro so that we understand which are the best candidate, maybe head-to-head, so that we got one panel that would really illustrate what are the best performances in terms of in vitro activity. And then this coupled with the experience that we have with the use of some of these repurposed antivirals, then it can be defined what might be a posology and a dose regimen that will be effective. Baloxavir, as said, should be tested as well, but the current data would look that is not a good option for Andes virus because you will need to use doses that are much higher than what used for influenza post-exposure prophylaxis and treatment. There are very promising monoclonal antibodies that have broad antiviral effect over different types of antiviruses, but they're all still in preclinical stage, so very early stage, not yet into first in humans. So we need to progress them very rapidly into clinical testing, and then to look into option, for example, of combination therapy with different monoclonals. We learned that they can be extremely vulnerable, and maybe having long half-life, that will be a really important feature to support the use in post-exposure prophylaxis. And then, as said, once the disease progresses to cardiopulmonary phase, immunomodulator agents are the one to look at, but we need to have a proper characterization of the pathophysiology, the endothelial dysfunction, and the vascular leakage, so that to target interventions and patient phenotypes accordingly. And we look forward, getting larger data set from this natural history study that was mentioned before, so that we can really understand when and how to use this type of immunomodulatory agents. I think that's all from my side. Thank you very much.
So thanks a lot, Marco. Marco. Marco in American is Michael, maybe, So thanks a lot. This was, we have a lot of messages that you have excellent presentation, as usual. And now we're going to move to the vaccine approaches. And this will be done by William Dowling from CEPI. Thanks a lot, Billy, actually, for your presentation. The floor is yours.
Great, thanks, Yasin. I'm Bill Dowling from CEPI. I'm going to present a landscape of vaccines that are currently out there. Next slide, please. Okay, so this is a look at the New World hantavirus landscape. So the dark blue squares are ones that have Andes virus antigens. The ones in the light blue are Sonombre virus antigens, and the ones in gray are multivalent, indicated in the boxes. As you can see, there are not a large number of candidates that have been tested out there, and the maturity level is rather low as well. So the most advanced candidate is had been in phase 1, is from Usamrid, a DNA vaccine from the group of J. Hooper, delivered by PharmaJet, and this has the M segment with expressing the glycoprotein precursor GPC, and this candidate in his preclinical data had efficacy in the lethal hamster model. And all the ones that have that type of data in hamsters is indicated by the yellow font. And this DNA vaccine was, again, administered by a device, and was multiple vaccinations were employed in both the clinical trial and the preclinical data. Also to mention that there was passive protection in this case when serum was administered to in the hamster model. So therefore, we know that there's antibody-mediated protection from this vaccine. So going back to other DNA vaccines that have been done, there was a Sinumbre, which again was not tested in the Andes model, so from the University of New Mexico some years back. And then the group at USAMRIID has also done various multivalent approaches, mixing several together, including one that mixed Sinumbre, Hantan, Andes, and Pumla, and showing good responses to each component and protection in the hamster. Then if we go look at the viral vectors, there have been VSV candidates, as well as some work in adenoviruses for Andes. So there's this work from Public Health Agency of Canada and from the Rocky Mountain Lab, NIAID. So in the VSV, that showed complete protection with single dose, and also some efficacy very close to exposure, and I believe they have some small amount of post-exposure data as well in the hamster model. And this was done with Andes, but they also did have a construct with Sinumbre, which also showed cross protection against Andes. But this is all preclinical material. I'll talk about maturity in a few minutes. Additionally, the group at PHAC also looked at various constructs in the Ad5 vector, not only some glycoprotein constructs, but also N protein, and all of these were also protective as well in the hamster model. There's a viral vector for Sinumbre that was in a CMV vector, but again, that hasn't been assessed against Andes, so I wouldn't touch more about it. And lastly, there's not in the literature, but from personal communication, there is an from University of Oxford that they have a Chadox construct, but there's not really assessment data available on that one. Then in terms of RNA, there's a publication from UTMB on an mRNA that was protective in the hamster model. There was also a second group from University of Texas, Austin, with a consortium that included Albert Einstein and HTT Bio, that made a self-amplifying RNA, a rep-RNA construct, which showed good immunogenicity data that was been published. And I have been told that there is efficacy data, but I've not seen it, so I can't report on that for sure. And the group maybe write this in the chat. I'm sure they're on the line if they are interested in talking about if there has been efficacy data on that construct. And then lastly, there's been some press releases in the last few days talking about that Moderna had teamed up with USAMRIID, and I've also had some personal communication about this. So there's some data there, but again, not been published or publicly presented. But there is some work in the using basically the construct that had been done by Jay Hooper's group and done in a Moderna background. And lastly, there was the same group that worked from Albert Einstein on the RNA also put out a paper on a nanoparticle approach using GN, and showed protection. I have at the end of the slide deck all the references, and so I can make the slide deck available to anybody who wants it, of course, and all the references are available. Next slide, please. Thanks. So just some high kind of overall points here. So first, just to be clear, there's no clinical grade vaccine material currently available for any of these candidates. The only one that was in the clinic was the DNA vaccine, and that has been depleted. So in terms of responding to this outbreak, I don't if it's in the near term, we don't have anything available. Material would have to be produced. Secondly, most of the vaccines have been assessed after 2 or more doses. The exceptions are the Ad5, which probably is not a clinical candidate, or the RSV, which were protective against, as I mentioned, against a single dose. So in terms of looking at a post-exposure type of, or even just sort of an approach that has been used often by this group in terms of ring vaccination, we don't really have data to be sure which candidates could be used for that effectively at this time. So I think that is definitely a gap. So the first gap is obviously getting clinical grade material for these vaccines. The second would be assessing which of them have efficacy after single dose. In terms of mechanism, we also, not on the slide, but I also, as I mentioned a minute ago, one of the vaccines, which is the DNA vaccines from USAMRIID, have looked at passive protection. So we know that there's indicating, antibodies can be protective. There's monoclonals that have been shown to be protective. So antibody can be a mechanism of protection. However, there are some other vaccines, as I mentioned a minute ago, there's an N protein-based vaccine that was assessed that showed protection. So that it looks like, the mechanism isn't completely clear on all these vaccines. And I see in the chat, someone just said that the US VSV shows post-exposure after a single dose. So thanks for that. Lastly, this analysis only included New World hantavirus vaccines, and kind of for the other speakers have talked about the dichotomy between New and Old World, and again, only full protection in the Andes virus lethal hamsters only been reported with New World. But of course, to mention though the caveat that there has been at least one report of Pumelo, which is a closer, of the Old World is the closest to the New World, showed some protection from Jay Hooper's group, showed some protection in the hamster model. There's also some vaccines, in fact one that's in the clinic right now, that's based on an Old World N protein, and that one potentially could show some cross protection. It hasn't been demonstrated yet, but one could imagine that there could be a greater breadth of T cell responses in that. So that is possible. So I think that in terms of the landscape, that's all that I was able to find out there. If there is more, I really, welcome. I'm going to put my email in the chat, and I would welcome any additional candidates out there. I would also welcome, in the comments that information as well. But this is all that I could find out there. Next slide, please. I want to mention one more thing. Thank you. So CEPI has been involved in developing multiple WHO international antibody standards, which are obviously useful for assessing immune responses. And we've done this for several vaccines, including the ones here, several viruses, including the ones here. And these standards are established by the Expert Committee on Biological Standardization, giving them an assigned unitage. And then it really allows you to compare between different candidates and different studies. By being a primary standard for calibration of national and secondary standards. So we're sourcing right now, CEPI, we would like to assist in establishing a standard that could then hopefully be brought to the ECBS. And we're sourcing convalescent samples from persons who have recovered from Andes virus infection. So again, if there's people that have material sources for this, suggestions, please, we would welcome that. And I'll put my email in the chat. And that's all I have today. Thank you. Oh, and in the chat, by the way, it was mentioned, one other thing, I thank you for somebody who's putting in the chat. There is a polyclonal serum available from, and that was tested as a therapeutic from transchromosomal bovine, from SAB Biotherapeutics. And so that is an excellent potential material, and I've been reaching out to them to try to get more information on that. But yeah, that's a very interesting. Thanks for writing that in the chat. That is a really interesting product and a very interesting reagent that's out there. And with that, I will pause. Thank you very much.
Thanks a lot. Actually, Billy, I also want to thank, because it's 32, so everyone has been completely on time. So we can now have, with the panel discussions. Just wanted to introduce the panel first, and then we will start asking questions. So Pierre Vandamme from University of Antwerpen and from the European Vaccine Hub. Hello, Pierre.
Hello.
Xavier de Lomballerie from INSEM and University of Marseille. Hello, Xavier. And Nicole Kitcher from University of Saint Sebastian that you met in the beginning. So probably, I asked Arpe that it is very important to have in this session someone from the endemic area. And so probably, Nicole, I will start with you. What do you think are the priorities for the countermeasure development here for this pathogen?
Okay, thank you very much for the opportunity. I would first like to make an emphasis that Andes virus infections have been really a priority for the sanitary independence of the state of Chile, right? And I think it must be very similar in Argentina. So the region has invested from their very tiny budgets that they have for science and development, right, for research and development, a lot of an important percentage on trying to get further insights, right? And those have been, of course, together with our international collaborators, also from our society, have been really focused on many, many things. So I saw questions in the chat that is not as clear. So they have really developed many molecular tools, first of all, to detect Andes virus, because, you can work on many different hantavirus, but the cross-reactivity, especially for the glycoproteins, is limited. And so very important, the contribution of Jay Hooper with the animal model. So Andes virus, this is still the only animal model besides of those non-human primates models. And then there are so important limitations to get forward to the development of those antivirals and vaccines. And most of them are because you really need a high biocontainment facility of maximum containment. And such facilities are extremely expensive to run. We, both Argentina and Chile, did an important effort now to have such facilities. They're under commissioning in our case currently. And but then we have the challenge to maintain them, right? So we got over the first important step. So I think having such a virus in our areas, it's so important to be prepared, to be able to manipulate and to work with them in vitro and in vivo. So so this is something I wanted to highlight, this barrier of a very expensive experimental undertaking to get as far to do the challenging studies. So the priorities would be to have a strategy, right, to do it in any sustainable way. And then, of course, it's key to have more insights on clinical prediction markers, as what's already discussed in the former session. I think it's excellent to have so much experience, so much eyes now on this topic, right? Because there was not as much attention in the field. Of course, we want to know much more human-to-human transmission, on the pathogenicity of the virus. Viral replication has been quite studied in vivo. And of course, as Gustavo showed, genome evolution studies. And again, I think the antivirals and vaccine approaches are key in the future. And there are many interesting platforms. Many of them are, most of them are still in preclinical steps, as was shown right now, because there was no commercial incentive, right, to advance towards gene production, fabrication, and then starting the first phase of clinical trial. I would like to highlight that we have excellent clinical network here in Chile, where such candidates could be tested in a comparative way once they have been shown to be secure, right? So all this I wanted to offer and also say that maybe those antibody cocktails are really important. There are single monoclonal antibodies that are highly neutralizing that have been published, and there are also patents on some others that have not yet been published. And maybe we should really work together to compare them and say, okay, what is really the best candidate? As we don't have these standards, as was already also mentioned. So
thanks a lot.
Thank you very much for the opportunity.
Thanks a lot, and thank you. And one thing you said, which is very important, you said that we will have now much more attention, whatever I think the future of the current episode. So one question I tried. There are so many questions that I was not able to follow everything, but at least to ask some of the questions. So maybe the first one to Ismail Bashir. So Ismail, one question that comes 2 or 3 times, whether we will have actually multi-respiratory pathogens panels. Do you think that this is something that is realistic or not? I think that if, I don't know if Ismail, I think that Nicole, you can respond too to this question, but I don't know, Ismail, are you there? It seems that, I don't know if you want to take this question, Nicole.
Sorry, what? I didn't get you.
Multi-respiratory pathogen panels for diagnosis.
Okay. Sorry, yeah.
It's fine.
We do only the specific ones currently. Yeah.
The question was whether it is realistic to have one or not, but it's fine. We can go to that. So then I move to the treatment. So Marco, again, thanks a lot. We have this morning this discussion at the ETF. So I will ask it again now, and maybe I will ask Xavier Lamballerie maybe to tell us whether you said that post-exposure prophylaxis, PEP, is the best strategy. There is a French protocol on preemptive therapy. So following in contacts the viral load, and when it is positive, to start the treatment, not as. So I just wanted to see what Xavier is involved on that, and to see his thoughts about post-exposure prophylaxis versus actually preemptive therapy, given the tools that we have. Because I saw in the chat the VXV vaccine, monoclonals with long half-life time. Today we don't have, we have favipiravir. So Xavier, what are your thoughts?
So my thoughts are limited to what we have discussed about the use of favipiravir first. We did not discuss this, for example, for monoclonal antibodies. I think that was really well underlined implicitly by Marco, that the expected antiviral efficacy decreases as we move from prophylactic use to early preemptive use, and finally to the treatment of the severe clinical forms. That's absolutely obvious. So what it means is that the decision is based on assessment of the risk-benefit balance, okay? And what it means is simple, but the decision is difficult to make. It means that early use should be a priority. That's very clear if you want to use these molecules, because they are not very active molecules. They are middle or medium efficacious molecules. And we need to find a cutoff between risk and benefit. In my opinion, it could be a prophylactic use in the event of confirmed exposure with a cluster or close contact with an infected patient. And it could be preemptive use for secondary or more distant contacts, something like that. So in our context, we had more to deal with the second category, secondary or more distant contacts. That's why we choose the preemptive use. But if we had, for example, to treat the patients on the boat, probably there would be no question for prophylactic use. So I just try to be a little subtle, not too rigid in that in the point that delineates both use.
Thanks, Xavier. So very interesting. You think that the question of post-exposure prophylaxis versus preemptive therapy is also a matter of what is the risk for the person to be infected in a boat where the risk is very high, the R0 is very high, you will say post-exposure prophylaxis. In a plane where someone come in and then go out, you say more preemptive therapy. Very interesting. Now, Marco, one question that was in the chat. I don't know if in the other countries, but in Europe, we don't have favipiravir. What we should do, Marco?
Yeah. Well, don't ask me. We should ask the manufacturer and try to understand what might be the routes for availability of favipiravir, because indeed I did not mention this and I should have done this. You know, availability of supply is really a critical factor. So we need to make sure that we have this antiviral available. Otherwise, what are we gonna do? So this really requires, you know, discussion with the manufacturers and maybe, you know, at the level of governments to understand, you know, what we can do in order to make sure that we can have access to this antiviral, which is approved in Japan, as you know, for uncomplicated influenza. And also, if I can say, yes, Dan, I saw in the chat also some questions about convalescent plasma.
Yes.
I think it's you know, we should not rule out that option. I think it's important that we always consider that, despite, you know, we've seen a lot of failures in the past, but it's true that, you know, convalescent plasma is something that can be available straight away during an outbreak. The important point with convalescent plasma that, you know, is really important to think about the dose and the titration of the antibodies is never a detail. And in the past, I've never seen this aspect really considered carefully from day one. But, you know, if the approach is taken quite seriously in a very scientific way, I cannot rule out that, you know, could be an interesting approach.
Thank you. Now, I just want to say that the Be Ready Pandemic Preparedness Partnership funded by European Commission, we have talked this morning with ETF and we try to do the best to have favipiravir. Nicole, you have a question, please.
Yes, sorry. I got so many chats from my colleagues telling me the reply to your question. So the topic is that the respiratory panels are usually applied in respiratory samples, but here we do diagnostics on the blood. That was the thing I wanted to clarify.
Okay.
Yeah. And maybe I also wanted to add that I think in these corks, it would be very important to explore carefully what has been done in these endemic countries already, right, as technological advance. And I haven't seen them in the presentations of the WHO, like a very important aims on neutralizing antibodies from colleagues here and also from my own group. And also vaccine approaches, not all are published, that I would like again to mention. Yeah.
No, I think this is a very important point, and I think Billy said at the end of you said, Billy, at the end of your talk, you heard Roger talking about the NAVIS protocol. So basically, I think that we should be in contact, and we should also take care of the materials. And you said we hope a lot of patients who will actually recover, and then how we. So Roger, I think this is you can. Iper has told me that we have until 55. So if you can say a word on that, because that is important, and then we will move to the vaccine.
Will be integration of efforts. So I would leave it there.
No, I think it is very important, and for example, now to link between the cohort study, NAVIS, and CEPI, for example, with this kind, I think very key. So now I try to move to the vaccine, and so Pierre, thanks a lot for being here. So there was one question that was on the chat. What are the biggest scientific barriers to vaccine development? Correlates of protection, animal models, manufacturing, feasibility, commercial incentives. And you know, we have talked since last Sunday a lot with Marco. Marco says something that I wanted to know if, as a vaccine person, you agree with. And actually, Billy, you can answer to the same thing. Marco is saying that now, today, for this disease, low incidence, what is the most important is treatment. Do you agree with that? Before going to the, thank you.
That's a question for me, Yazdan?
Yes.
Yes, okay. Well, I think indeed what is the priority now is to have the immediate interventional tools. That is clear. But I will immediately add to that this is also a perfect opportunity to see how we can now quickly respond also with vaccine development and further refinement of the vaccine landscape, because this is, I would say, a very good fire exercise for any outbreak in the world. So to test, in fact, our rapidity of reaction, of collaboration, and bring together all the expertise that is available, and that I also see now, I would say, minute after minute identified and shown in the chat. So I think that's a way indeed to move forward. But clearly there are priorities now, which are the interventional tools. I agree.
And regarding the biggest scientific barriers, what do you think about that?
Well, to come back to that question, and I saw that question in the chat indeed, and I think what we have also now discussed within the European Vaccine Hub this week is to really have also very performant animal models. Most of the studies have been done in hamster, in Syrian hamster. Would be good also to move a bit closer to the human situation, I would say, through non-human primates. We know this is not evident at all. There have been also studies in macaques. So any further experience and testing at that level would be key, I think, to move forward. But I also look at Marco, what the regulators will expect in this preclinical pathway, what will work and what can be used in the dossier that will be submitted. Having very good challenge studies in animals, and in particular then in macaques or in non-human primates, would also help to move forward, and perhaps give an approach to a correlate of immunity that will be needed, because now we know some of these candidate vaccines, and it was also shown by Hooper in his publications, do induce neutralizing antibodies, but in which way are they really protective in humans? So that's exactly the step that we need to know.
And can I, a final question before giving the floor to Iper? To you, no, sorry, excuse me. Marco and then William. No question, I didn't saw your hands, please.
I will be very brief. First of all, animal models. The Syrian hamster model is the only model, that is really useful here, because it's standardized uniform lethality. And while with the macaques, there's been attempted in the past, but I don't know where we are at the moment, and we need to look back at this. But then when it comes to neutralizing antibodies, and I replied to Jay also in the chat, I agree. It looks like here we could have a strong case for very high level of neutralizing antibodies that could be protective. So passive transfer studies in the animals will be really important to consider, but also natural history. We need to collect data on natural history and see what happens to humans, which apparently they never get reinfected. Of course, is a rare event, but nevertheless, whatever we can say with respect to the role of neutralizing antibodies will be important to streamline, development of vaccines. And of course, single dose will be very important for outbreak containment, while multiple doses will be okay for endemic use.
Thank you. And yes, please, Billy. Well, in William, you say Billy, right?
No. Well, I don't. But I go by Bill. Bill is fine.
But because it is written Bill, but William then, sorry. Okay.
No, that's okay. Bill is what I usually, it doesn't matter. Anyway, so just to reiterate, everything that Marco said, I would agree with. In terms of the model, we don't have a disease model except the hamster, and I know that there's work that Jay's has been talking to me. I know he's doing work to try to make that, make the model really, standardized, more ready for, maybe a regulatory package than perhaps it is. But I completely agree, though. We really need to know the information on the different candidates about, number one, how they're, mechanism of protection. The only thing we know, the only one we really know anything about that is antibody mediated for sure is the DNA vaccine that Jay has done. The other ones, they haven't done passive transfer, so that would need to be done probably. But also the whole idea of, is how many doses do you need for protection? because I think if you need many doses, it's going to be difficult. I think a lot of the ways we would assess this type of vaccine isn't going to be through a large preventative campaign, because we, who are you going to vaccinate? It's very difficult. If you want to do something, respond to a situation like this, you need something that can give you somewhat rapid onset of protection. And so I think we need to take the candidates that are out there, and the only ones that, as I mentioned in my presentation, the VSV a VSV candidate has been looked at, but not all the others yet. So I think that information will be really important going forward. So, and
thanks a lot. I think that we're going to close this session. Thanks to all the panelists I think we had the best session, right?
I can't have
thanks a
favorite.
lot.
I don't agree.
No, it is just a joke, of course. We should talk. So thanks a lot, Iper. So 7 minutes before.
Fantastic. Yes, and thank you. Thank you to all the speakers and panelists in your session. That was so much ground to cover. I don't really need to say very much to wrap up before I hand over to Vasi at WHO to make some comments and to close for us. Clearly, we've highlighted the importance of collaboration here, and we're already demonstrating what it can achieve through some of the things that have been discussed. It's happening before our eyes in the chat. I know much hasn't been, answered there, but we're going to take all of it away to work on in these working groups that we've mentioned. We've put in a link to this survey, and we'll do it one more time if it hasn't just gone in already. We've already got nearly 100 responses so far, but we know some important contributors will be missing there. There are 3 text boxes. Please just tell us what you think are important for the working groups, what the working groups should be, what they should cover, what are the opportunities, the barriers. We really want to do our best to then set an agenda for meetings that address different thematic areas, so we can really drill into how we accelerate countermeasure development and the research that underpins that. So thank you all for everything that's coming forward. The CORCs were an initiative that the WHO R&D blueprint launched under the drive, the oversight of Anna Maria Henao, and they have been incredibly successful. We will all know that she recently retired, and we thank her for everything she did. The world's eyes are on the CORCs outputs now. Already GLOPED-R have reached out for a readout from this meeting, and CEPI are interested to know. They have a regulators network that, what are the regulatory barriers that we might need to highlight. So please do put anything that you think needs to be carried forward into those conversations, into those forms. That's all I'm going to say for now. We will be in touch with the next steps. Thank you everybody that was that helped put this agenda together at WHO. To all of the chairs that hosted such wonderful sessions, to all of your speakers and your panelists. You are convened at short notice, and what you have come together to do collectively here today has been just tremendous. And with that, I'll hand over to Vasi for final comments from WHO and to close the call. Thank you.
Thank you so much, Aoife. Can you hear me okay? Yes. Not much to add. It's been just such a pleasure to listen to all of this scientific discussion. I mean, our key desire here is to enable scientific collaboration so that we can systematically identify ongoing knowledge gaps and address them. I just want to thank a few people. So firstly to UK HSA, as Aoife said, the CORC initiative was driven by Anna Maria. So I just want to acknowledge that. I think we're seeing here the fruits of the leadership of the R&D blueprint under Anna Maria. Now that she's left, we need to continue and take this further and really embed this. What we're really doing here is acknowledging that we do have limited resources in WHO, but we have an absolutely extraordinary network of scientific collaborators around the world. So we're formalizing this ability for us to convene even more than we can do simply as WHO staff. So the CORCs are going to continue to have a greater role. We have a scope of work to really solidify exactly what this role is going to be, but you are going to see this in the outbreaks going forward. For example, Yazdan is on the line, and ANRS is the Filovirus Corp, and we have equivalent bodies for all of the viral families. I also want to really take a moment to acknowledge, I won't talk for long, but I think it's important to acknowledge a few people. So Patrick Leiden and Jimena are absolutely core members of the R&D Blueprint team. I don't know how if everyone knows them. I don't know if they could put their cameras on if they're on. They have been working on this for many, many years under the leadership of Anna Maria, and they're absolutely phenomenal. We have many, many other folks in the team. I just want to mention Roger has been working full-time on this with Libby, who has come in from a previous very, very senior position. So Roger and Libby, thank you so much. And there are so many others that are taking this forward. With everyone's help, we'll get there. As Eva said, this is one of a series of engagements, and we look forward to everyone's contribution as all of this moves forward. And I should mention that I am speaking on behalf of Sylvie Briand, who is the leader. The leadership for the R&D Blueprint is within the science division where I am based. But as is, I think, clear to everyone, we are also the research pillar of the incident management team in WHO of the response. So we work very closely across WHO. So with that, shall we close the meeting now, and we wish you all a very good evening.
Thanks all.
The recording will be available as has been made clear.
Thanks.
Thanks, everyone.
Recording stopped.